Okay, I think we should probably get started. So thank you everybody for joining us today. It's wonderful to have so many people online joining us, and a few people in the room as well. So thank you all for being here. Today's session we'll be talking about informing culturally sensitive neonatal palliative care. And this is based on some research that Clancy at the University of Exeter and myself, also from the University of Exeter, have been undertaking over the past 18 months or so. We're also delighted that we are joined by Michaela Halfhead, who's a clinical educator in the Northwest Neonatal Operational Delivery Network, and Rebekah Walsh, who's a bereavement midwife and birth reflections manager at the Royal United Hospitals in Bath. And they're also going to be talking a bit later on about their work. So just to get started, a couple of housekeeping things. We'll be recording this seminar. I hope that's okay with everybody. And we'll be putting it on our website at the end of the discussion today. So if people want to share it or send a link to other people, please feel free to do that. Also, because we're expecting quite a large number of people online, it would be great if people could keep themselves on mute. And there'll be plenty of time for questions and discussion after the presentations. So thank you. Marie, the first slide. Thank you. Just as a quick agenda, we'll be talking through the project that Marie and I have been undertaking, first of all. Then we'll have a quick response to these findings from Michaela and Bex. And if there's any points of clarification from the audience, that'll be an opportunity then to ask any points of clarification. We'll have a break for 10 minutes, and after the break, Michaela Halfhead will be talking about international nurses in neonatal palliative care, and Rebekah Walsh will be talking about training and continuing professional development. And then we've got, hopefully at the end, about half an hour Q&A. Thank you. So fully recognise that many people on the call today work in a neonatal palliative care setting already, but not everybody does. So just to give a little bit of background on what it is we're talking about here, we know that around 2,000 babies each year in England and Wales will require a palliative approach to care. And neonatal palliative care aims to embrace the wishes of parents at the earliest opportunity, while focusing on the needs of the baby and enhancing the quality of life for the whole family, however long their time together may be. It aims to improve the experience and outcomes for families during a time of crisis, specifically when the baby is not expected to survive or when a baby has multiple complex health needs with an uncertain future. And although often used interchangeably, palliative and end-of-life care are not synonymous. Palliative care can include end-of-life care, but it's much broader and can last for months or years. And whilst death rates have steadily decreased over the past 5 years, what data shows us is that those rates remain exceptionally high for babies of Black British ethnicity, where stillbirth rates are over twice those for babies of white ethnicity, and neonatal mortality rates are 43% higher. Similarly, mortality rates remain very high for babies of Asian and Asian British ethnicity, with stillbirth and neonatal mortality rates both around 60% higher than for babies of white ethnicity. What we also know is that economic factors play an intersecting role here, and data shows us that more babies born to mothers living in the most deprived areas of the UK died in the neonatal period when compared to mothers who lived in the less deprived areas. But what we also know is that the experiences of ethnically diverse families receiving palliative care is really under-researched. We really don't know very much from the published literature around people's experiences here. And what we also don't know is about the challenges facing healthcare professionals who work in this speciality. And this in turn, this lack of research specifically aiming to understand the needs of these families can actually make those families feel reluctant and disempowered to share their experiences. So it's a bit of a vicious cycle here of a lack of knowledge and then people not feeling able to get involved in research that's going on. Marie, next slide, thank you. So just briefly as a background for this study, The aim of the study was to understand how neonatal palliative care is being experienced by parents from culturally diverse backgrounds and the challenges facing different groups of health and social care professionals who work to support them. 21 health and social care professionals and 4 parents from across England and Wales were involved in this research and participated in interviews and focus groups. We recruited professionals through the neonatal palliative care networks, and this included neonatal consultants, nurses, bereavement midwives, chaplaincy, interpreting services, international nurses, and people from the charitable sector as well. Just as a sort of overview around the key themes that we're going to look at today, these include need for effective communication, bereavement support, religious, spiritual, ethical and moral considerations that need to be taken on board in neonatal care settings, and the need for CPD, continuing professional development. I'm now going to hand over to Marie, who's going to talk through the findings.
Thank you very much, Felicity. So just to start with effective communication, then you'll see that one of our participants said that neonatal palliative care, how important communication is in the quality of support that they want to give to families. And lots of participants said to us that language barriers were the biggest challenge they have, and that they are related to inequitable care. And there's just a quote here from one of the neonatal nurses that we interviewed who talks about the inequalities of just providing conversation, really, information and communication, where obviously Western families who speak English can get that very quickly, very easily throughout the day on a neonatal unit. But families who don't speak English actually possibly only get one opportunity a day, if that, to ask questions or have their needs addressed, which obviously is quite inequitable. When we talked about interpreting services, a lot of the health and social care professionals did share concerns with us about how difficult those, the extra difficulties those brought about in terms of organisation, paperwork, and quite a bit of bureaucracy was seen across the NHS, really, and community services in terms of how staff managed to get hold of interpreters, particularly if they wanted the same interpreter. Often that was quite difficult, and it did sometimes seem to put staff off getting those services involved. However, most people did recognise that there were large benefits to getting professional interpretation, particularly in terms of an extra person that was able to communicate with the family, build trust and relationship, and actually communicate with them and help them to get their needs met. There was also quite an awareness that for some families, staff interpreted them as having good enough English, and actually within neonatal palliative care that wasn't really enough. So often interpreting services were needed because things were technical, or there was specific terminology or complicated treatment that needed explaining, or steps of process. So actually for staff to consider that good enough within this field and ensuring that things were understood. You'll see from this quote here that actually one of our participants was mentioning that the word funeral wasn't known, and I suppose we'd all perhaps assume that that would be a word that everybody would understand, but obviously there aren't always English interpretations for every single word or every single thing. Lots of people told us about how actually it was quite difficult to work with interpreters, not because the interpreters themselves were difficult, but because it added this third person into the dimension. And so actually they would really relish some training on how to work effectively with interpreters. And also it was recognised that interpreters themselves could benefit from training and support. Lots of the interpreters didn't have specialist training, and that seemed quite inconsistent across the country in terms of what training they received. And there were quite a few situations and examples that we were told about where interpreters were left trying to deal with a very difficult, challenging situation, particularly around end-of-life care, without formal training or support from their profession. You'll see here, these are some quotes from parents, lots of fear there in terms of not being able to speak English, not being able to get things explained. Again, I think perceptions are important here to note. One of the mums said that she felt that staff couldn't be bothered to communicate with her because she couldn't speak English, and perhaps they didn't make the attempts that she was hoping they would. And another mother there at the bottom just acknowledging that you can't get interpreters all the time. And I think we all know, those of us in the neonatal palliative care field, that there are changes to condition, there are deteriorations, there are critical moments that can't always be predicted. So actually that can be very difficult for families to not get that support when they need it. Just moving on then to bereavement support, which was something that a lot of participants spoke to us about. There were quite a lot of stereotypes and assumptions made about informal support networks that culturally diverse families could utilise, or that families were being supported through faith communities. And I think it's just important to mention here that that wasn't always the case. You'll see from the Muslim chaplain that we spoke to, who said that she realised that lots of people thought the mosque was supporting the women in her area, and actually they weren't able to do that. They were giving spiritual advice, but not actually emotional or practical advice, because they didn't feel equipped to do that. So there was a sort of missing link there. It was also acknowledged by a lot of participants that they weren't utilising traditional bereavement support either. And that seemed to link to a secular view in bereavement support services, which didn't always align with participants' religious or faith beliefs. There was a notion that a specific area for bereavement within the hospital would be very useful. Some participants spoke to us about the benefits they saw when they had that area. And you'll see the quote here at the bottom from the neonatal nurse, who was saying that actually having a specific area was very, very beneficial to families. They were able to give better staffing and better experiences, particularly at end of life. And you'll see, I suppose, the rationale for that sort of thing by one of the parents, who's talking about seeing all the other babies getting better and realising her baby's getting worse, and the comparison between cases there when everybody is together. Another thing that was noted really is that the bereavement training seemed quite diverse across the country of what neonatal teams were able to access or able to have. Some of the teams were very fortunate to have specific bereavement staff who were able to provide training, but not all of them had that facility. And so one of the bereavement midwives was talking to us about actually involving the chaplaincy team and other people when the bereavement team perhaps possibly weren't available, so that somebody was there to help families 24/7. Unfortunately, though, the chaplaincy team did seem to be frequently misunderstood. Some people who'd worked closely with them were able to talk to us about the benefits of having multi-faith chaplaincy within the hospital and how that was helpful to them. And again, there seemed to be quite big disparities across the country, depending on whether the area was culturally diverse or not, in terms of what was available to families, how often that was available, and what chaplaincy staff could provide. But it actually, when chaplaincy staff were used, it did seem to really help build a bridge between families and staff and provide additional space, which was impartial for pastoral listening and support, as well as spiritual advice, particularly at end-of-life care. And just to move on to that spiritual element, really, what we found was that there were quite a lot of differing expectations, and they were very common, but they could very quickly lead to misunderstanding and moral and ethical distress for staff. So people did speak to us quite a lot about difficulties, particularly in terms of withdrawing life support, and how there were often divergences of belief between staff and families, and that could result in distress for staff who perhaps felt like babies were left receiving invasive care, whilst families were counselled or communicated with about whether that should stop or not. And the difficulties of kind of aligning families' expectations with staff expectations. And again, I think language barriers did seem to play quite a large part in this, where staff couldn't communicate, or families couldn't communicate clearly between the two groups, and so they weren't able to express what their needs were adequately. And you'll see here, this is an example of when those divergences happened. Within this example, a family were being discharged home, as that was their request to have their baby die with them at home. And but they did seem to change their mind quite quickly, which was very confusing for the staff. And obviously it takes a lot of time and attention to organise end-of-life care at home and discharge from hospital. So the staff were quite frustrated when the family changed their mind. But actually it was only when the Muslim chaplain was involved that the staff were made aware that the reason they had changed their mind was actually related to the need for a burial, and that the family didn't want to go home and not be able to bury their child on a weekend. So it was only when that Muslim chaplain became involved and actually was able to build that bridge between the family and the staff that it became apparent why that change of mind was there, and that obviously it was very, had quite a big rationale behind it. And I suppose it just highlights to us all really the role that chaplaincy can play in helping us to understand some of those needs that might not always be obvious from the outset. As I'm sure lots of you on the call can imagine, continuing professional development was a big theme and a big area where more training would be very useful. There's a little list here of some of the things which were suggested to us that would be very helpful. And again, I think you'll all realise that resources and finances obviously played quite a big part in the restriction of some of this training. But actually there was a lot of suggestions of why this would be very useful, particularly in terms of things like anti-racism training, to ensure that staff were actually moving their practice forward and actually being quite active in trying to avoid any discriminatory practices in the clinical sphere. Self-awareness and bias training was also suggested. Some areas were using really gold standard training, and there was a lot of simulation that was happening with medical staff, nursing staff and interdisciplinary. But again, this did seem to differ depending on where staff were working. And you'll see there the training for interpreters that I mentioned previously. So there were some opportunities and obstacles, as you can imagine, in terms of communication. It was very quickly recognised that actually, particularly within palliative care situations, that informal interactions and building rapport was very important. And some of the staff did give us examples of when they'd actually been able to communicate with families more informally and how beneficial that had been to building trust. You'll see here that we've mentioned translators and interpreters needing training, resourcing and preparation. And actually preparation is the part I've not mentioned previously, as often it seemed that interpreters were thrown into situations very quickly without a real handover from staff of what they were actually going to be involved in and what was going to be discussed with families. And obviously that can be very difficult for interpreters if they are not prepared and they don't understand the medical terminology that is being used, that they are being expected to translate. One of our participants talked about sending follow-up letters, and there was sometimes some cultural diversity in terms of gender roles and perhaps who was translating for who. And actually this participant thought it was very helpful to send a follow-up letter and offer different lines of communication via email or telephone, particularly to mothers, to ensure that they did understand and that they could have that letter translated later to ensure that it was being understood fully. Google Translate was also something that was used for informal conversations. We obviously wouldn't suggest they were used for essential medical conversations, but they seemed very useful for chatting to families. One nurse did speak to us about translating the milestone cards that are used in neonatal intensive care into different languages. And what came across very much from that example was actually how making the effort to do that translation was what had meant a great amount to the family, not necessarily whether the verbs and grammar were completely accurate on those cards, but just that she'd gone to so much effort on a night shift to translate things so that that family could send pictures to their wider family back home and be involved in a similar way to other mothers on the unit. One of the community nurses that we spoke to that was involved in children's palliative care, as obviously a lot of these children from the neonatal settings will move into children's palliative care later, talked to us about the use of advanced care plans and how the wording of when these things are used is quite essential in terms of helping people to communicate their needs and perhaps not have to reiterate things over and over again when these plans can be used. They also talked to us about using other communication aids for spotting deterioration as well, and how that could be quite useful for making sure parents were actually okay and managing all right, and that they were coping with the complexity that some of these children brought to the family. It was also suggested having literature in a range of languages and mediums, i.e. things like UNICEF information sheets, and also things like asking very simple things, actually, like asking parents what they preferred to be called, ensuring correct pronunciation of names is used. I'm sure you all realise there's software now where you can actually have names repeated back to you. And again, I think that's about valuing families and really taking time to use proper pronunciation of their names. Also things like the language used by families. Not everybody will be mum or dad or grandparents, and obviously in different languages it might be different terms that are used for those familiar names as well. Just to link back to the religious, spiritual, ethical and moral considerations, there needs to be a recognition that families are experts in themselves. Obviously different kinds of support is important, that we're offering that, but also recognising that that will not be for everybody, and that for example some families may prefer to gain informal support rather than professional support that's offered. But that doesn't mean that things shouldn't be offered, just that we need to value people's ability to make decisions for themselves, really. There was quite a bit of discussion about professional curiosity and how important that was to ask questions and check understanding in terms of whether staff were understanding families correctly. And obviously training can really help that to develop confidence and make sure that we are reflecting on our own beliefs and biases when we are having these interactions. Some of the staff we spoke to, particularly in the Northwest, talked to us about how having a multicultural staff team and lots of different staff from around the world actually really helped them to gain different perspectives and to understand families' perspectives, and actually for those people to educate the rest of the staff, which seemed a really valuable resource. Lots of staff spoke to us about clinical supervision, how important and helpful that was when it was provided, and that could help them to manage distress from conflicting beliefs about care, and obviously the grief of when they did lose babies, and had to support families through that. And I think I've already mentioned a little bit about geographical differences in service provision and resource. And that also related to the availability of chaplains of different faiths. Within the West Midlands, actually, the community nurses spoke to us about having chaplains that were able to go out into the community as well, which seemed a really valuable resource to them. So not only were they available in the hospital, but they were also available to do visits and things like that, particularly for bereavement care. So what we have been doing as a research team is we've been trying to develop some key questions for consideration rather than providing a recipe book of recommendations. What we thought might be more helpful is to develop questions that individuals could ask themselves, but also that organisations could be held accountable to and consider within their different settings, as obviously we realise that these will need to be quite bespoke depending on the service that is offered across the country. These questions have been developed through a workshop which we ran with different people within this speciality to see their opinions and to help us to formulate these from our research findings. So I'll just very quickly go through some of these. I don't think any of these will be a massive surprise to anybody on the call, but these relate to the themes. We will have time later to discuss any of these if anyone has any thoughts on the wording of these or if they think additional questions need to be asked. So at a service level, we thought it was important to ask about the access of interpreters. Are they available face-to-face? People did talk to us a lot about how valuable it was to have interpreters face-to-face rather than online or over the telephone if possible. Obviously, these are potentially paid for in different ways, and that can be quite important when it comes to potential hostility or blame or financial restrictions. So it might be quite important to look at those things. What support is available for interpreters? Again, some of the services in more multicultural areas seem to have some really great service level provision that they had developed in terms of providing their own staff and expanding the range of dialects that they offered. Written information in different languages. Obviously, you might not want to be printing all these things out, but you might want to have access to these. And I know there are other facilities like doctors around the world that can sometimes offer those things as well. And then you've got service providing adequate opportunities for continual professional development, particularly in cross-cultural communication and listening. And then you'll see here, we've also got some questions for individuals to ask in terms of thinking about how you adapt your communication style to suit individual family needs. What can you do to improve this? Obviously, people can use these questions for self-reflection and thinking about opportunities to gain feedback and reflect on communication skills. I think when people are in training, there seems to be quite a lot of opportunities for this, but post-registration, maybe not so much, and maybe that's something we need to develop further. Also thinking about good cross-cultural communication and thinking about how we are able to kind of role model some of this gold standard practice so that other people can see that, particularly our students as well. Bereavement wise, again, these relate to some of the things I've already mentioned, so I won't read all of these out, but thinking about specific areas, spaces, whether faith-based facilities are available, and thinking also about specific bereavement training as well. Obviously, we want individuals to know about the chaplaincy services that are offered in their location and how these might be helpful to them. And also thinking about any assumptions that might exist in your local community and how we can try and find out whether those are accurate or not, and making sure that we're not basing our care around myths that we're unsure if they're true or not. Again, some of these link together, so I won't repeat those, but thinking about community support structures, as Felicity mentioned earlier, thinking about charities that may work in the sector as well that might be able to provide additional support, and also thinking about obviously individual level and where biases may arise and how we can try and address those. One of the key areas that seemed to be an example that was frequently mentioned related to things like pain and how we provided that for neonates, particularly thinking about the transition from life-sustaining to end-of-life care, and making sure we understood what different beliefs there might be around pain and why those might exist to help us understand them better. So just a brief opportunity to say thank you to everybody who participated in our study. We had great support from the neonatal networks and we're very, very grateful for that. And particularly to Joanna Bennett, I think she's on the call from the Southwest, who has really helped us as well in our particular area. So thank you very much for that. I think I have actually surpassed all expectation of myself in terms of keeping to time. So thank you for that.
Can I just add one more acknowledgement onto this as well, and that's to Hayley Redmond, who's with us here in the room today, who's been a brilliant source of support for us throughout this project and in organising this seminar today. So thank you, Hayley, as well. So thanks, Marie, for the overview of the findings. We'll come on to questions later on, but before we do, if anyone has any points of clarification on what you've heard, now is the time for that. If you want to put a hand up or put something in anything in the chat. If not, I can't see anything. What we will do is move on to a response to the findings from Michaela and Bex. So Michaela, over to you.
Thank you very much, Felicity. My response, first of all, that your findings are very, very accurate when it comes to communication is key, and also finding out who are we dealing with, listening to them and finding out what they would expect in their own country, in their own culture, and then realize what is the difference in our culture and what we would normally provide, so they're not totally shocked. Interpreters are a big issue, you know, have them face to face is so important. We spend a lot of time with our international nurses talking about communication and language and speech, so really, really important issues that you've highlighted. So I don't know if Bex wanted to add anything to that.
Yeah, very happy to. I agree with you, Michaela. I wasn't surprised by the findings, but really good to have this research done. Anyone who works in palliative or bereavement care around the loss of a baby knows that it's a really unique experience of grief. But we also know that our expectations around the loss of anybody is steeped in our families, backgrounds and our culture, and so we have to marry this unique experience of when a baby dies in with those cultural and family expectations, and that's what this research really highlights, is how we address those two things together. So I'm really grateful for the research. I think the findings and questions are really thought-provoking.
Mention articles that they're going to.
Oh yeah, so thank you, Michaela and Bex. And as Marie's just reminded me, we are hoping to publish a sort of a short summary of the findings in Infant Journal, which many of you will probably read or have access to. And the questions, the questions for consideration will be highlighted in those articles as well. But yeah, we can't tell you when that's going to happen yet, unfortunately, but hopefully they will be there at some point. What we're going to do now is have a break, so the captioner can have a bit of a break. And if we can meet back in 5 minutes, 10 minutes, should we say 10 minutes? 10 minutes, yeah. So at 1:45, please, that would be great. And then we will hear from Michaela and Bex. So thank you, everybody, and we'll see you shortly. There we go. Okay, can everybody hear? Yes, great. Well, welcome back, everybody. What we will be talking about for the next part of the session is international nurses in neonatal palliative care and training and continuing professional development. So I'm just going to reintroduce Michaela because a lot of people came in a bit later on and may not have caught this earlier. So Michaela is clinical educator in Northwest Neonatal Operational Delivery Network, and she's going to talk to us about her amazing work she does with her colleague Rosie on supporting international nurses in neonatal services. Michaela, over to you. Thank you.
Thanks, Felicity. Yeah, I just wanted at this point to acknowledge my colleague Rosie, who was the main driver in developing this programme for international nurses. So following the recommendations from the Neonatal Critical Care Review, there was a lot of a big recruitment drive in neonatal nursing, and it was attracting a lot of international nurses with valuable neonatal experience to this country. Unfortunately, international nurses do not possess a recognised qualification in speciality, and so they were still required to follow the Northwest pathway, which was quite lengthy for them. And often their knowledge exceeded the training that was provided on our foundation programme, which was normally 6 months, then follows on to the QIS part, which is another 6 months. So together with Rosie, an alternative fin was designed and run by myself and my colleague. And we found it really beneficial, first of all, to support those international nurses when they first started in post, and provide them with a framework and evidence for their experience. Secondly, to enable them that they use their experience to progress much quicker and reduce the time away from the cot side. And thirdly, to support them culturally as they transition into the neonatal units of the Northwest. So we designed a short program called the IR Fin. That was only 12 weeks and ran 6 study days, live sessions, virtually via Teams. We have now included actually one face-to-face day for one to join the others, with a lot of scenario work and some independent learning. The resource and learner pack that we use on the long foundation program is available to them as well. But a lot of their knowledge really exceeds all this, but it's good for them to back it up. We used a lot of video clips, reading materials, and gave them links. It includes also a competency book for their clinical skills to demonstrate their skills in practice, and a 2 to 4 week supernumerary time in intensive care with a level 3 unit. Next slide, please. So during the live sessions, we had a lot of communication with the multidisciplinary team, with parents, and that was really helpful for them. So we provided them with some case scenarios that we asked them to do some, to sort of check their knowledge and understanding, and then provided them with what we would do in this country after asking what they would do. And there was quite marked differences sometimes, and they learned a lot that way. So learning about their cultural adaptation to this country, we've watched videos about human factors and how they maybe should react differently here. A lot of it was to do with communication, with the way, for example, how parents speak, how to speak to parents they found really, really difficult, because quite often in their own countries, they weren't allowed to communicate with parents. Only doctors were allowed to disclose things. So they found this really, really difficult. Obviously, language complexity. We spend a lot of time going over different types of slangs, even within the English language, like the northern, the southern slang. Just for them to be able to pick up the phone was such a difficult thing. So we talked a lot about examples of how they could introduce themselves to parents and how to engage with parents to make that first connection. And then really also talking to each other about and to their colleagues, their English British colleagues, how just watch them and see how they interact with parents, and slowly that encouraged them to be able to speak and communicate a little bit more. Challenging doctors was very difficult for them because, again, in their country the hierarchy is very different, and challenging a doctor would absolutely be not considered appropriate. So again, you know, sometimes they have to learn to speak up for the parents and for the baby's sake. So we invited parents to come and talk to them, and they found, again, this really, really helpful to speak to parents, to hear parents' view. But then we also played them videos about other colleagues and how staff sometimes communicate, and then we had discussions about what is good about this and what would not be so good. FICARE, family integrated care and neuroprotective care, was a completely new concept to most of them, and initially found that really difficult, but absolutely they really love it, and they feel they would like to take it back into their own countries, having spoken to them. And we discussed all sorts of processes like transfer, discharge, safeguarding. Bereavement especially was a very big issue for them, and the bereavement care that we provide in this country is so different from what their own experiences is. So we discussed that in detail, and that's why we invited Marie and Felicity to come and talk to one of our groups. We went through national guidelines and Northwest guidelines and talked a lot about NMC standards and the code, which included speaking up for the patient. Next slide, please. So this program's been run for a couple of years now, usually 3 times per year. We've had over 100 learners on it. Not every international nurse is suitable. We try and keep the numbers to around about 20-ish, plus minus. A few sometimes drop out, because we want to have really good discussions of the case scenarios to establish the knowledge, to be able to sign them off. And so we have like 2 groups of 10 usually when we have discussions. And as you can see here, this year it's tailed off quite a bit. So we've decided not to run the April program, because at the moment the recruitment drive is slightly halted. So we'll have to assess and see whether we can incorporate them in the long fin for now. Next slide. So we have had a few challenges. So we have challenges with OSCEs, PINs. Not all the IR nurses, as I mentioned, have got enough experience that we feel they can carry on this course. There was a lot of sickness and absence. Pastoral support was needed from a lot of them. And like you mentioned before, one of the ladies in the chat, psychological support was needed. We did invite our clinical psychologists, which we really incorporated into our program now as well. That was very beneficial. They also need a lot of help with academic level if they then move on to the university part of the QIS. And a lot of them want to go on the masters, and they have not got the right academic level of writing. So they need a lot of help with that. And they also they had challenges with the rest of the team. Next slide, please. So how did we address these challenges? We now make sure that all of them have passed their OSCE before they go on the program. Even if they haven't got the PIN, at least we know it'll just be a few weeks for the PIN to come through. Standalone communication days, we have developed a few of those and ran a few of those with the international recruits who do not have any neonatal experience. So they might have come from an adult background or a pediatric background. So they're not suitable to go on the short program. They will go on the long foundation course. However, they really need the communication and the cultural aspect. So we provide that in a 1 standalone communication study day. And that's really beneficial for them. So we recognise the challenge of a different climate. That's why they have a lot of sickness. And so especially the winter month, when we started those winter month courses, there was a lot of absence. Also when their children were brought over, the children go to school and play school and bring a lot of germs home, and the whole family was ill for quite a long time. So a different climate made a big impact on the whole families. So considering the amount of annual leave requested was another thing about enrolling them on the programme, because if they do go home and repatriate a family, they do tend to stay. Obviously, it's a long flight, costly, for a whole month. And if they would miss too much, then might have been better for them to go on the next course. So these are the things that we've addressed. We've been very lucky with some of our larger units. For example, St Mary's in Manchester, they have had so much experience with their international nurses, and they've got their own advocates, international advocates, who've gone through the whole programs themselves. They provide great pastoral support and came onto the program and helped us. They've provided a handbook with lots of local information for them. Just things like where do you go shopping, how do you enroll your child into the school, go to GP and things like that. So they have great WhatsApp groups, and their support is really great. And then we've asked the HEIs to provide some specific training for them on how to critically analyse, so they can then go on to the master's level of the QIS, just to improve their academic writing. Next slide, please. For the rest of the team, so first of all, we've learned a lot through running this programme, and then we felt we really needed to share this with the wider teams of our units. So we held several webinars for supporting international recruits. Also, Rosie has spoken on a couple of national study days about our international programme, and we are happy to provide any information about the programme to anyone if you contact us. The journey of an international nurse is quite long. It can take 2-3 years to get to the UK, and it has massive financial implications. So it probably costs more than 2,000 now. They have provided a really great journey board on their unit in Manchester, where people can see what sort of hurdles they have to jump over to get to this country. So it's really important to recognise all their cultural differences and the problems they face with the complexities of our English language. Next slide. Oh, sorry, one back, yeah. So I heard Felicity and Marie talk on a national palliative care meeting about their research, and they were struggling to recruit, obviously, or approach parents who have just lost a baby. So I thought maybe our international nurses would be a great source of knowledge for them. So we invited them along and used a whole group of our nurses who were really happy to join to share their personal knowledge of palliative care from abroad. And we found there was quite a lot of information. After initial quiet period, if you remember Marie and Felicity, then they were quite open to use their knowledge and share their different cultures, different languages they would use, and explain the different faiths they come from. And it's really important because they can really feel for those parents. They have that real empathy because they also come from a different cultural background. They've gone through the same emotions of feeling lonely, alienated, and displaced from home. Next slide, please. So what does the future look like? So we feel that we really value and accept the value of our international recruits, very much so. Without their help, our future looks really bleak. We're struggling with nurses as it is, so their international knowledge, their experience, and just the sheer numbers of them is so helpful for us. They really appreciate us. We get some fantastic feedback from them, and they're so grateful for any support that we provide to for them to adjust to our culture. So we have shared out the handbook with other units in the Northwest, and they've adapted this handbook from St Mary's to their own units, because obviously it's different in every area. We have provided them with a bit of sort of links and information of where they can get some financial support, especially if they initially fail maybe once or Solioski, because that becomes quite a big financial burden to them. And it's really great if every unit can provide somebody who's already an international nurse and has been there for some time and have their own advocacy team there. So they teach us so much about themselves, and it's really, really valuable. So this is the end of my part. So if anybody has any questions, I'm happy to answer them.
Thanks ever so much, Michaela. Does anybody have any immediate questions that they would like addressed now, or we can come back to this area when we have the main questions at the end? Can't see any hands up. Okay. Thanks, Michaela. We're going to move on to our final talk today, which is Bex Walsh. And again, just for those who came in a bit late, just to introduce Bex. Bex is a bereavement midwife and birth reflections manager at Royal University Hospitals, Bath. And she's going to talk about training and continuing professional development. Over to you, Bex. Thank you.
Thank you very much. So my passion really is around training. I'm the bereavement lead in Bath and look after all losses in pregnancy, stillbirth and neonatal. And we have recently 2 years ago, put together a whole training day for our teams, mandatory for midwives, but available for our neonatal team as well. And so that's sort of what I'm bringing to you today to talk through. So I just wanted to start with a few kind of key points when we think about training and when we're providing it to trained healthcare professionals, midwives, nurses, doctors, healthcare assistants, and even psychologists and broader, is what do we need to be thinking about when we're ensuring that that is culturally sensitive? And the first thing, I suppose, is exploring unconscious bias. I think that comes up a lot more these days. Some of you on this meeting may have done Black Maternity Matters, may have done some cultural awareness training, and probably will have come across the term unconscious bias. Now, at the bottom of this slide, there is a film called Bike Thief. And actually, if you put bike thief and racism into Google search, you will come up with this film. But if you get the slides afterwards, you can click on the film. The film is 14 years old, as a caveat. But it's an interesting, thought-provoking short film to think about that unconscious bias specifically around racism. And really important to be aware that when we're teaching or talking about unconscious bias is that it can be uncomfortable, and probably if it's not uncomfortable, we're probably not doing it the right justice. The fact that it's unconscious means that it's happening, we're unaware of it. It's something that is sort of been wired into us because of the experiences that we've had in our lives already, and happens in a split second without us noticing. So to stop and notice that is a challenge, but really important to do. If you want a really quick way of discovering some of your unconscious biases, if you're on Instagram, for example, go and look at who you're following. And is there a theme? Is everybody that you're following of the same cultural background, for example? How much diversity is there in what you're exposing yourself to? And once we start to make ourselves aware of our unconscious biases, that's when we can mediate for that, and we can approach families in a culturally sensitive way. And that cuts across the board, from palliative care, bereavement care, to everything that we do professionally and outside of our professional lives. So I think that's a really important thing to talk about in any care, but particularly around these sensitive times of life when a baby is dying. Professional curiosity is really, really important. But within that, thinking about what do we need to know? Because the families with whom their babies are going through palliative care, or their babies have now died, it is not their job to teach us their culture. It is not there for our personal curiosity. They are not there for us to learn from them. The professional curiosity is about us saying, what is most important that we need to know about you to deliver the best possible care? And so really important to be curious, but to remind ourselves why we're being curious and what's the burden on the family when we're curious about their cultural background. We do need to avoid assumptions, and that comes a little bit back to unconscious bias, and it needs to come everywhere. A really good example is, most of us will know Christian families who will attend church at certain key points or key events in the calendar, but may not at other times in their lives. And so they're choosing in and out of which parts they prefer to adhere to. And that's that avoiding assumptions no matter what. I've put cultural practices in here, and SCT are our spiritual care teams. When we have a family that are culturally diverse, our spiritual care teams are a great source of resource. We can go to them and say, I have this family, their cultural background is da 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 da. What might I need to know? And that prevents that family from having to teach us. We can take what we've then learned from our spiritual care team to the family, and this is what I'm aware of. How does this fit for you? What is most important for you around that? My third point is around consistent offering of options. That is around, again, assumption making really is, if we have something that we are able to offer, we need to offer it to everybody without making assumptions about what they may want or may not want. A good example of this is it's much more widely available now to donate breast milk after loss. There can be some assumptions around that, that a family may not want to do that. They might want to reduce their milk supply. There's issues around kinship, around Islamic families. But coming back to those assumptions, actually, we don't know which parts of that is important to those families. Feelings of worth comes around to if we have made an assumption and not offered a family a particular option, and at some point later down the line, they find out that other families were offered to donate their breast milk, for example, and they weren't, most families will run on the assumption that I wasn't offered it because my baby didn't mean as much, or we didn't mean enough. And they tend to apply that I was given less options because I'm worth less. And that's that, actually, let's be brave and let's offer everybody every option that we have available at our unit, but document those so that we're not overwhelming people by asking them repeatedly. And then my fourth note there is representation matters. So representation is thinking about what is in our training materials. Do you have culturally diverse examples in your training materials, culturally diverse pictures in your training materials? What about on your neonatal units, in the bereavement leaflets, in palliative care leaflets? What's the language there? What are the photos there? How are we ensuring that we are representing a broad range of diverse backgrounds within that? And next slide, please. So a quick note about how-to guides. One of the things I get asked most is, Can you create a checklist for that? Can you create a how-to guide for that? Can you write a step-by-step system on how we're going to do this? And yes, how-to guides are really good. Checklists are really, really good. However, we can, usually out of stress and anxiety, get a bit stuck to our script and forget about the family that is directly in front of us. And so it's really ensuring that our checklists are there as a prompt. They are not there to prevent that really good communication with that family. It's that age-old thing of, am I looking at my script or am I looking at the person that I'm talking to? Parent-led seems very perhaps common sense. Our national bereavement care pathways that are led by SANS is very much sort of parent-led. Our palliative care pathways inform us to be parent-led. They are the experts in them. They are the experts in their family background. However, we do need to be thinking about who else could be involved, who else could we ask. So it may be that within a family, actually, that those parents are overwhelmed, but it could be that there is someone else outside of the parents that may be able to help. And that could be your spiritual care team. It could be a religious leader for them. It could be someone that is considered as an elder within the family that would be able to inform us as healthcare providers as to how best to support that family. Equally, it may be that the parents want to be very private and held within that, but it's thinking just a little bit more broadly wherever possible. Checking in regularly, unfortunately, with how-to guides is we often go, oh my goodness, I've got all this information that I need to provide this family with. And so we try and get through all of it. But actually, there needs to be that regular stop, check in with the family. What are you understanding now? Do you need time to process that before we carry on? And just having that reminder to really regular check in, particularly when we're using interpreters, the time that parents may need to just process that information, particularly where language has been challenging, or we're using specifically medical terms where interpreters may be struggling to interpret as well, allowing that space, allowing them to go away and talk to other people or read information in their own language and then come back with questions. And at the end here, acknowledge, apologise and explain. I think this is my favourite 3 words whenever I'm delivering training, thinking about how-to guides, or you're in a challenging situation with families. So acknowledge, what are we struggling with? Have I got 20 things that I need to talk about today? Am I struggling with an interpreter because they're on the phone? Is it a new interpreter to this situation? Is it the first time that I've met you and I need to find out what's important to you? So acknowledge what the challenge is right now, apologise for that, own that, apologise that they're in this situation. I'm really sorry that your baby is so unwell. I'm really sorry that your baby has died. I'm really sorry that we're needing to go through so much information at this really difficult time. And then explain what we can do to meet in the middle. So you know there's a challenge, we've apologised for that. How are we going to do our best? And sometimes that comes down to saying, I'm unable to get an interpreter face to face. I'm really sorry for that. We'll talk about it, but then I'm going to provide you some written information so you can go away and we'll arrange another meeting where we'll try and do better with an interpreter. And I think that's a really helpful tool to just remember when we're talking to families, particularly in challenging situations. It could simply be that it's a first time for you as a healthcare professional having to discuss this topic with a family. And so in giving training, I think providing people with really practical tools, and that's a really simple one to remember, really helps to build people's confidence. And when we build confidence in healthcare professionals, we also build their resilience, which means that they will still require support. These are still challenging situations, but hopefully less support because we've built their resilience. Next slide, please. Okay, so I just wanted to touch a little bit on grief and complicated or traumatic grief. Grief is an interesting topic. I think it's still quite a taboo topic in this country. I think it's taboo, grief in any situation, when we lose a close family member, a friend, an elderly relative. But there are really additional things to be thinking about with babies that may make that grief complicated or traumatic. Now, somebody mentioned earlier around counselling and psychological support. In the diagnostic manuals, some of them are now labelling some types of grief as complicated or traumatic, and they haven't really got a good definition around that. But that's when actually psychological services can be helpful for families. But certainly grief in itself is a normal, natural process. And I think it's really important to acknowledge that we cannot reduce, we cannot prevent grief, and it absolutely cannot be cured. There is nothing that you can say or do that makes the grief better. And in fact, to stop grieving for someone who we love might suggest that we don't love them anymore. And along with that, thinking about the lifelong relationship that we're hoping to have with this baby that we no longer have, is that grief will change over the years, but we carry it with us. I think helping healthcare professionals to really recognise and sit with the idea that you cannot make the grief better helps to take a little bit of weight of responsibility off them, that they're not expected to make it better. However, we do know that we can complicate their feelings. So where there has been poor communication, where there have been misunderstandings or a lack of knowledge around what is going on, where we have minimized people's grief, where we have not offered a family something that they later find out that they may have been offered, whether they wanted it or not, or where we look after someone in an environment that is particularly difficult. If your baby is dying and you're watching other families in their joy and excitement of taking their baby home, for example, all of these sort of things and many, many more I'm sure people can think of can add to or complicate their grief. It may add in anger, it may add in feelings of guilt, of frustration, and therefore the grief can be much harder to process within that. And I've already touched on the absolutely unique experience of the loss of a baby and the loss of that child's life, and the lifelong experience of grief is something that we're not very good in accepting, I think, amongst families. And if we can really challenge ourselves to be accepting of the fact that this is so unique and this is lifelong and that this grief doesn't get better, then actually we give permission and allow families to experience the grief in the way that feels right to them. And I think that's the end of my slides, and I'm very happy to take any questions or to pass back to questions for everybody.
Thank you so much, Bex. That was really, really insightful. Okay, this is the Q&A session. We've got a fair amount of time for this. So there's already a question for you. I'm assuming this is for Bex. Do you offer the training externally, Bex?
I don't formally. It is in-house training. However, it is rarely full. So my email is on the end of the slides. And if you're local to Bath and want to send me an email, I'd be very happy to have some external people absolutely come and join. You'd be very welcome.
Just to say as well about the QR code there that's on that slide. So if people wouldn't mind scanning that in, I don't know if Hayley, if you could just put the web link in the chat as well for people. There's just 4 simple questions on there, including your name and email address if you're happy to share that with us. And if you could give us some feedback about today, we'll pass on any feedback to Michaela and Bex if it is specific to their sessions and their topics as well. But you can also put on there is an extra section for you to write in if you'd like to be involved in any future research with myself and Felicity, and what you think our next priority should be. But also there's an additional comments box there, so please do write in there if you would like a certificate, and we will make sure we get one of those sent to you as well at the end of the session.
Just looking through the chat for any earlier questions. Ellie had a comment on counselling bereavement support, which wasn't mentioned much in our initial discussion. Obviously, something that Bex has touched on in much more depth, but I don't know, Ellie, if you think there's anything else you'd like to come in with there, please do.
Can I add just briefly on the conversation about counselling and psychological support, is that counselling can be certainly helpful, but certainly with psychological support and thinking about complicated traumatic grief, that's not something that they would diagnose and offer treatment for until at least 4 weeks post loss. And I think that's probably why it didn't come up so much in the research, because it was very much focused on what healthcare professionals are delivering, and that certainly from a psychological point of view is a little bit later down the line. Counselling can certainly be a bit sooner.
Just to add on to that, we did speak to quite a number of bereavement midwives, and one thing that people commonly said was that families just sort of dropped out of the system after a while, and they found it quite difficult to maintain contact with the families who are at the centre of this research. It's obviously an area where more understanding is needed. Ellie.
Hi, thank you for this. It's been really interesting listening to you. I just wanted to kind of add to my point that I made, and also to what Bex just said. I would see, I'm the lead psychologist for London for neonatal care, and I would see psychologists and psychological professionals as contributing beyond just offering therapy. So I would see them, you know, in a similar way to the way you talked about chaplaincy support, offering universal support through training, through staff support, and through the ways in which they make themselves available to families beyond just kind of bespoke pieces around, say, trauma or complex grief. So that was why I was surprised that they didn't come up more in the discussion, because I do think there's real complexity with families when they don't understand the offer. And I think often staff don't understand how to make the offer of psychology, and therefore families often don't understand it. I think there's a lot of stigma around psychology and what that means, and whether it means that you're not coping or some kind of risk to you and your family. So yeah, I was more just, I'm interested that it didn't come up as a theme, and it may be because we're still woefully short of psychological professionals on neonatal units. So the provision isn't there everywhere yet, and lots of staff may not be aware of that, but I would like to see there being more, because I think they're a real resource in this area.
Well, thanks, Ellie. And I think absolutely it's not something that kept coming up in the research. So I think that lack of resource is definitely a core issue. And I think probably speaks to one of the findings that Marie touched on around the sort of geographical differences in provision as well. You know, in some parts of the UK, we definitely found that people were really just having to kind of make things up as they went along, but be very resourceful and creative in how they supported families, because they just didn't have anything like that, and people were having to do it kind of out, you know, off their own back, I suppose. There weren't the systems in place to actually support them doing that. Whereas in other parts of the country, you know, there were multi-faith chaplaincies. There were in-house interpreting teams. You know, in other areas, people were having to either call in to interpreting services or put a call out to staff in the hospital and get them to come and interpret. So there's a huge diversity in what resourcing was available to people. So I'm sure that that plays a really big role in psychological support too. Well, thank you, it's a really important issue. Ingrid, put your hand up.
Sorry, I'm on my phone because my laptop doesn't allow me to log into it. I'm struggling a little. So I come from a general end-of-life background, and I've worked for many, many years with complex grief, but work in children's and young people continuing care now. So my speciality within all this is very new. But I just wanted to add that the question that I've raised the most and has really always had the most kind of success, if you like, in getting to understand what people are going through is when you ask your questions, generally as nurses, as midwives, whatever your profession is, when you ask, are you married? Have you got a partner? Have you got family? Ask within that if the person is supported, because that's the one assumption that is often made in many contexts in English families as well as in foreign families, is that just because there is a husband, that means support, but it might not. And in terms of determining what is complex grief and who might need psychology input throughout that process, the question of are you supported gives you, for me, the most profound answer in all of this initially. When someone deals with a death, that's just what I wanted to kind of say and add. I find it really powerful, these presentations.
Thanks, Ingrid. Michaela.
Yeah, thanks, Ingrid. That was great as well. But just what I wanted to reiterate from speaking to all these international nurses, that it was so important from speaking to them and other families from a different cultural background, is really to first of all not assume that they know what's going to happen here with bereavement and palliative care and support. And I know a lot of our parents probably don't know what's happening, but they come from such a different culture to really find out first what would they normally expect to happen. So really ask a lot of questions from them to say what happens in your own country, because the grief and the things that we're expecting might be completely different in their culture, and they will not show the same reactions and although they're all different anyway, but they are again so different from that different cultural background. So they might really struggle if you're trying to refer them to a clinical psychologist or to any other support. They just shut that completely down. That's just not their culture. So it's really important to find out from them what is it that we can help with, and what would you normally expect to happen, and how it differs in this country, and what is available to you here that they might choose to access, maybe not in that moment, maybe at a later stage, but just to make it available to them, because they might just not normally react that way. Thanks.
Thanks, Michaela. Ingrid, is your hand up again, or is that from last time?
An old hand.
Yeah.
Yeah, your legacy.
Legacy hand. Okay. Do we have any other questions? Ellie's put useful link in the chat. A chat says staffing standards for psychological professionals for neonates. Thanks, Ellie, for that. Marie, is there anything?
Any other questions from anybody? There's a question from Ted there. Hi Ted, welcome.
Thank you. I'm sorry for joining a little late, but I'm here now.
Thank you for joining us. We appreciate us. Did you want to speak to that question?
Yes, I can do. Yeah, why not? So I wasn't here at the start, so I didn't know how the first 45 minutes of the session went, unfortunately. But what I wondered, just with my experience as a neonatal consultant delivering a service to a range of people across the Northwest, as we're a large tertiary unit, is whether the disparity in depth of the services available in different locations around the country is more to do with individuals pushing for what they feel is important in a certain area than it is with funding. That's not to say that funding isn't challenging across the board, wherever you're working, whatever you're trying to get funding for. But somebody has to make a decision about where the money is spent. And it takes an individual or a group of individuals with drive and passion in a certain area to be able to achieve success in what it is they're trying to do. I'm in the process of trying to connect with other like-minded people within neonatal palliative care. This is both sort of in the hospice level, charity level, as well as looking at organisations that support the NHS and within the NHS to see how they achieve funding for the services that they're providing, and how to try and standardize that across the board, because it's not always just about cities versus what's available in the rural environment. It's often to do with which part of the country you happen to be in and who's working there. I just wondered whether you had any feelings about that with your project. Obviously, it's spread across different parts of the UK.
Really interesting question, Ted. Yeah, I think absolutely that more socio-cultural element is really critical here, in terms of what people are used to and in terms of what people feel that they can or can't push within the setting that they're working within. And if you have a team of people around you who are like-minded in achieving a particular ambition or aspiration, I'm sure that makes a huge difference. Whereas if you're an individual working alone, I think you're probably going to feel more limited in what's possible. Although, as I mentioned, we did see some individuals doing some incredible things and really, really driving an agenda, but not necessarily with that team around them to be able to sustain it, I suppose. I don't know, Marie, if you want to come in there, but I think it's probably a question we can open up to everyone on the call, because we've got people here from around the country. Marie, did you want to?
Yeah, I mean, I think if anyone's got any examples, please do raise their hand and we'll come to you to if there's any support we can offer, Ted. But I'm just wondering as well, and we've got our head of the nursing school here with us, so we might ask him to do with whether people think that they're equipped to kind of get in on this kind of a bit more political, I suppose, and social change type sphere in terms of addressing inequalities, because I think there is a lot of people, like you were saying, Ted, maybe don't feel equipped to move into that world of sort of, they know that the resources are not there to do what they want to do, to provide the level of care they feel they need to, but how do we address that, and are people equipped within our nursing, medical and otherwise professions to actually address some of those challenges? I don't know what you think, Rich, about them.
Well, it links quite nicely actually to something that I was reflecting on just from your research findings around the kind of questions for consideration, which I think are a really clever way of sort of framing that. But I suppose one of the key things I was reflecting on was like, where's the policy question? Where's that higher level above the level of the organisation or the employer, that actually how do you ask that question to the right person at that policy level that then actually starts to address some of the really clear inequalities that you've identified through the research that I think also Ted is picking up on as well. So I think there is a role about how do we move into that sphere of influence, and how do we move into that place where we can actually influence some of those more wider policy questions that try to address maybe some of the more systemic and structural inequalities that clearly exist across this particular area, and try and really kind of address that. And I don't know how to do that, but I think that probably those that are on the call today have probably got really good examples of how they have locally affected that influence and how they've managed to do that, and then how you could potentially scale that up.
Yeah.
It's interesting, isn't it? I'm just seeing the extra comment from Ted there about obviously acknowledging the different funding possibly about different locations, but also that difference of drive and passion to achieve success. And I think it's certainly something we've seen, is that passion for addressing inequalities and moving towards social change does seem to be more apparent in some areas and individuals than others, doesn't it? So that's interesting in itself, I think.
Yeah, I mean, I wonder if it's something that people on the call can reflect on either now or on the feedback forms in terms of different areas and teams that you've worked with and how you see that playing out there, and any sort of reasons why you think that might be the case. I think it's a really critical question. Does anyone want to come in with any experiences they've had there? Somebody? Michaela, thank you.
I think, yeah, even if you haven't got sort of psychological support, I think the chaplain teams are very underused. They are such great communicators and can sometimes, specifically for the different religious faiths and beliefs, sort of really be the one who connects us with those families. And like you presented in your talk, that one person who came in to explain the change of the family's mind, you know, it is just so important to use them. But I definitely think whoever drives it, there's definitely more psychological support available, not just for parents, but also for staff. If there's a drive from a person in sort of at a managerial level who can push that. So that's what I've experienced up here in the north. Thanks.
Thanks, Michaela. Bex.
I can't work out how to put my hand up on the computer, sorry. Thinking about that kind of national level and funding and drive, see, so in our hospital, we piloted the National Bereavement Care Pathways back in 2018. And so on an individual level, that's been me that sort of pushed for the training, but that is supported within the National Bereavement Care Pathways. And those pathways cover neonatal loss and sudden infant death up to 1 year old. And I believe every trust bar 2 in England has signed up to those. So there is some responsibility on the seniors within each hospital that have said, yes, we're signing up to these, to actually follow through on some of those standards. And I know they're being looked at again to ensure that they are really addressing cultural diversity as well. And they are very specifically around bereavement. So that real sort of not clinical, what do we do, but that care element around the family, including that psychological well-being. So I wonder if that's where the drive, interestingly in Scotland, they've made it mandatory. So all Scottish hospitals will have to adhere to those standards. And that's probably where we need that drive to ensure that, like Ted says, you don't have a bit of a lottery, a postcode lottery really, as to where you are. But there are systems. So we, in our local maternity system, are trying to, what we're doing in Bath, trying to get that replicated elsewhere, and, you know, and then broaden it out. But it's absolutely challenging, and we need that sort of top-down drive as well as the individuals at the bottom to kind of push it through and provide a standard that is the same wherever you live.
Yeah, absolutely. I mean, I think that there's so much to be said for that top level systemic and organisational backing, and for that to kind of lead so that it can filter down at all levels. And I know in one of the workshops we talked about the need for training to be mandatory rather than something that people were expected to do in their own time. And you know, making it mandatory would actually then elevate it's in people's minds and in their working practice, I think, as well. And I know in other work I've done around sort of cultural competency, thinking around cultural competency within healthcare, this kind of notion of recognition for the work you're doing as well, and going that extra mile, it not just being, you know, a one-off or well done pat on the back sort of thing, but actually it being more formally recognised as something that everyone should be aspiring to do as part of their job, and that it's being recognised within the broader sort of occupation as well, in terms of things like promotion and recognition more broadly. So, you know, there's sort of quite obvious things I think that could be looked at here. Marie, did you want to add anything?
Yeah, I think the other things we are looking at as well is in terms of obviously myself and Richard are heavily involved in nurse education, and I think what we're also thinking about is when we perhaps get people to think about these things, and I think actually getting them to think about inequalities in their pre-registration training is very important. Obviously we need a lot of post-reg training as well to top up on that. But one of the things we are looking at doing, if anyone is interested in being part of this, is working with some bereavement charities and looking at whether we can actually get children, young people and bereaved families to help educate healthcare professionals, and whether some creative practice like art or other creative work might actually help to people to see different perspectives and obviously different cultures as well, and what is, I think Bex mentioned, you know, what is important to individual people, and so that we can see that breadth of that it is very, very diverse, and that it obviously might change day to day as well. So we are looking at doing some creative work and obviously some education around different cultures. I think what Bex said was really important though, that we should never be looking for a recipe book, because that doesn't exist. You know, it's not about saying every Muslim family will require this or need this or should be offered this. You know, we still need to make sure that those decisions are individualized to the people in front of us. But what we could do is start to show people the value, a bit like Michaela and Rosie are doing, of culture and international families, and what they bring to the UK and how valuable that can be, and perhaps showcase some of that value rather than problematising families, which I think is the tendency a little bit at the moment. So yes, please do get in touch with us if you are interested in that. And there's just some of our email addresses. So obviously if you have specific questions for Michaela or Bex, they're very happy for you to email them. And equally, if you're interested in more the education or research side, please do contact myself or Felicity. Is there any other questions in the chat, Hayley, that we need to? No other questions in the chat? No
Questions. Just to say that we will share the slides with everybody who signed up for the meeting. A little bit further up the chat, Hayley's put a link into an overview paper that we wrote about 6 months ago, and gives an overview of what the data tells us about who's using neonatal palliative care, and what people's experiences are, but also what we don't know, what's missing from that data as well. And as we mentioned earlier, we're hoping that there'll be some more research papers that come out of the research that we've discussed here today. They'll be coming out in the next few months. So yeah, sort of watch this space, and there'll be more there. Added in another comment.
We also have a poster as well that we've created for neonatal areas, so with some bits of guidance from these findings. So we will send that out to everybody as well, if you do want to print that out and put that in your areas for staff to have a look at. And again, I think our contact details are on that poster, so if anyone would like to give us any feedback on that, we'd appreciate that as well.
It's just added.
Yes.
A link in the chat. It's about the new framework for integrated prenatal palliative care, which came out on Friday, which has a section on how to start conversations about spirituality and cultural considerations. So that sounds incredibly relevant. Thanks, Ted. Okay, unless there's any final questions. We've been talking for a very long time. So I'd just like to say a huge thank you to Bex, to Michaela, and to Marie, and to everybody who's joined us today. Thank you all very much. Have a good rest of the day.
Yeah, thank you. Thanks. Bye.
Thank you. Bye-bye.
Watch the water go down the plug one little.
Yeah, okay, let's go on. Okay. Bex, we were just going to say a huge thank you to you. It's been brilliant to have your input, so thank you ever so much.
Oh, very welcome. Was that all right? It looked really good.
That was great. I have to say your voice is very soothing. I felt it listening off when you I mean, it was really nice to listen to, but it really, really you're very articulate.
Yeah, thank you.
Yeah.
Well, you're very welcome. It was I can do the talking, but as long as I don't put people to sleep.
No. Thank you.
Very welcome. All right, well, I will leave you to it.
Yeah, we'll be in touch, Bex, about the articles and things.
No worries. All right,
Yeah,
speak soon.
thank
Take
you.
care.
Take care. Bye. Just leave now, shall we?
Yeah, maybe some people have sort of drifted off.
I think we can end it for everybody at the bottom there, right? Let me do that.